30% of relatively healthy people like you and me, who are getting their blood drawn, have positive anti-nuclear antibodies. But right now, about 4 out of 5 people with autoimmune disease are women.
You brought up ANA, the anti-nuclear antibody. That's one test. Let's talk about what that is and the top signs of autoimmune disease people should be aware of.
Dr. Sara Szal
is a groundbreaking physician, Harvard and MIT graduate, and New York Times bestselling author who is redefining modern medicine.
Known for her innovative approach, she's more likely to prescribe a continuous glucose monitor or microbiome restoration than the latest pharmaceutical.
As the director of precision medicine at the Marcus Institute of Integrative Health and a sought-after global keynote speaker,
Dr. Szal is leading the charge at the intersection of mental and physical health, personalizing care with cutting-edge technology.
Her latest book, The Autoimmune Cure, continues her mission to revolutionize how we approach chronic illness and wellness.
Toxic stress can be a trigger for developing autoimmune disease. And then this 3-legged stool that Alessio Fasano first coined as a requirement for developing autoimmune disease. It's number 1.
We saw a lot of negative things happen during the pandemic. I would love to hear your thoughts about it in terms of your feeling on if this was contributing to the rise in autoimmunity.
The problem is, as a researcher, it's...
Welcome back to the Dr. Brighten Show. I'm your host, Dr. Jolene Brighten. I'm board certified in naturopathic endocrinology, a nutrition scientist, a certified sex counselor, and a certified menopause specialist. As always, I'm bringing you the latest, most up-to-date information to help you take charge of your health and take back your hormones. If you enjoy this kind of information, I invite you to visit my website, drbrighten.com, where I have a ton of free resources for you, including a newsletter that brings you some of the best information, including updates on this podcast. Now, as always, this information is brought to you cost-free, and because of that, I have to say thank you to my sponsors for making this possible. It's my aim to make sure that you can have all the tools and resources in your hands and that we end the gatekeeping. And in order to do that, I do have to get support for this podcast. Thank you so much for being here. I know your time is so valuable and so important, and it's not lost on me that you're sharing it with me right now. Don't forget to subscribe, leave a comment, or share this with a friend because it helps this podcast get out to everyone who needs it. All right, let's dive in. Dr. Sara Szal, welcome to the show.
Thank you, Dr. Brighten. So happy to be with you.
I'm really excited for today's conversation. If anyone's not familiar with you, I often say that you walked in women's health, really paving the path for hormones so that everybody else could run. And we could really expedite the healing, the information, the conversations that we need to have. So everybody, this is the reason why I think we feel we can talk about hormones in the way that we do, thanks to you.
Well, it's very generous. I would say that it's women who've really help to pave the way, and women who are saying, I'm not going to put up with this anymore. Like this way that we're treated, the way that we're dismissed, the way that there's not enough education about women's hormones, about perimenopause and menopause. So I appreciate your kind words. I also feel like it's witnessing this massive gender health gap that has been the primary motivator.
Yeah. Well, okay. So I want to talk about autoimmune disease today and hormones and women's health, but you just mentioned the gender gap in healthcare. What is that? What should women know about that?
The gender health gap is this really massive rift that we have between men's health and women's health. And the way that, research was not conducted on women for such a long time because they were considered too complex compared to men. So whether it's the stress response that was studied in the 1930s, or even the use of hormone therapy on women for 59 years before a randomized trial was done to look at whether it was a good idea, there's this massive research gap, and then it shows up as a massive gender health gap. So things like the way that drugs are used in men, how that's been studied very thoroughly. If you look at something like Ambien, and then it's assumed to apply to women, and it often doesn't. So women tend to have more side effects. And it just leads to, you know, a long list of statistics that show that women get the short end of the stick.
And when you consider that there is, a significant amount of harm being done in medicine by gaslighting women, ignoring women, and then we also have this gap of information and knowledge of how do pharmaceuticals work on women, or how do, these interventions affect women differently? Even looking at something like, how do women experience heart attacks? They're not just the standard, chest pain, arm pain that we think of as men. It can be as simple as looking like upset stomach, like they are having digestive issues. And all of this definitely contributes to why so many of us have felt stuck and why so many of us have really had to DIY it ourselves, which, thankfully you write books and we have lots of information available. Yeah, we all write books, right? Having this information available so that women can take charge and put it in their hands. And I think, as you were saying at the top of this, that has really been one of the biggest instruments of change in women's health.
It is. And you're speaking to a really important point, which is that there's sexual differences. So there's differences between those that are assigned female at birth and those that are assigned male at birth. And then there's also gender differences. So when you look at something like a heart attack in a woman and the atypical symptoms that women have, because coronary arteries are smaller in women, we tend to have more microvascular disease in the heart compared to men. We, instead of the classic substernal chest pain, like an elephant is sitting on your chest, women have, as you described, more gastrointestinal symptoms like nausea, jaw pain, a feeling of doom. And then when women seek care, there's then a gender difference, which is socially constructed, so that if they see a male physician in the emergency room, their survival is half or even lower compared to if they see a woman in the emergency room. So there's both the sex differences working against us and then also these gender differences.
Mm-hmm. I appreciate you parsing that out, because I think sometimes all of those things get lumped together and we're not recognizing that they are, in fact, distinct, and they have to be looked at that way and really examined through the lens of what biologically is your body doing and then what is happening because of bias. Now, I do want to talk about autoimmune disease. You have a new book that you did a wonderful job outlining autoimmune disease, and especially as women, what we need to understand. And as I was preparing for this interview, I was looking up, I'm like, where are the statistics at now for autoimmune disease? And according to the Institute of Health, as many as 50 million people in the US have an autoimmune disease. And it is now the third most prevalent disease category, only surpassed by cancer and heart disease that we were just talking about. Specifically for women, how prevalent is autoimmune disease?
It's incredibly prevalent. So the statistics, when I looked at what we've got in terms of prevalence, I was amazed that they're old. The data is about 10, 15 years old, and there's no national organization in the United States that tracks what's happening in terms of autoimmunity or the progression of autoimmunity to autoimmune disease. So these statistics of somewhere around 25 to 50 million people affected in the United States with autoimmune disease are old and probably outdated. So the more recent statistics, including talking to a colleague of ours, Mark Hyman, who has a lab test that he runs on people, and he's had 100,000 people sign up to do this lab test. What he's seen is that 30% of relatively healthy people like you and me, who are getting their blood drawn, 30% have positive anti-nuclear antibodies. Mm-hmm. And it's not just him reporting this anecdotally. The data is showing that there are certain populations that are that have this uptick in terms of autoimmunity, especially anti-nuclear antibodies, where you have an antibody against the nucleus of your cells. And I'm one of them. So this is part of what motivated this book because about 7 years ago, I tested positive for anti-nuclear antibodies, not just a little bit, but a pretty big amount of these antibodies. And we think that the pandemic has also increased the prevalence of autoimmunity. And so when I speak about this difference between autoimmunity, or what I think of as pre-autoimmune disease and autoimmune disease, there's a spectrum here. And we know that the people that have the greatest increase in prevalence are adolescents and also men. So women already have a pretty high prevalence, and we can talk about some of the reasons for that. But right now, about 4 out of 5 people with autoimmune disease are women.
That's huge. And why are we seeing an uptick in adolescence?
You know, it's hard to say exactly what the reason is, in part because we don't have enough research money going into this. But I would say it's some of the culprits that you and I talk about a lot. It's a toxic culture that is really stressful. We know that toxic stress can be a trigger for developing autoimmune disease. And we can talk a little bit about, what's the three-legged stool, what leads to a diagnosis. And then I would say our food supply, big food, the way that it's poisoned us in many ways. I think that's a huge factor in terms of our immune system just being pummeled in a way that it wasn't 100 years ago. I have a great grandmother who died at 97. She was born in 1900. So it always is helpful for me because the math is easy. She's someone who had a very different food supply. When she ate an apple, it was like a cute little green apple that was not very big. And food dramatically changed since 1900. And we know that there are certain foods that tend to trigger the immune system. Things like gluten and dairy and nightshades. So our food supply has changed. The amount of stress that we manage has dramatically increased. And then this three-legged stool that Alessio Fasano first coined as a requirement for developing autoimmune disease, it's number 1, genetics, number 2, increased intestinal permeability or leaky gut, and then number 3, a trigger. And it's the latter two that you can actually do something about. But the trigger is interesting. And when you look at trauma as a trigger, which we see in about 80% of people who develop autoimmune disease, our experience of trauma has increased. And so that's another potential cause that these triggers have increased.
Yeah, it's interesting that you bring up the pandemic because I think people's minds directly go to the virus itself, which certainly we know viral illness can trigger autoimmunity. And certainly COVID, we were seeing autoimmune disease, new diagnosis, new antibodies coming up. However, the thing that we're not supposed to talk about, it feels like, because, somebody always rushes in to be like, it was all necessary. I mean, history will tell us if it was all necessary. I think it was incredibly traumatic to be isolated as humans, to be shut down, to not be given a playbook. We didn't have a playbook to the pandemic. None of us knew what the best thing was. We were living in a lot of fear, a lot of shock. People were losing loved ones without being able to be there with them by their side, not having closure, being able to attend a funeral, not being able to attend weddings, graduation, births. I know birth trauma really increased during the pandemic, especially for Black and Hispanic women. We saw a lot of negative things happen during the pandemic. And yet I feel like the only thing that gets focused is, well, there's a virus. That's why there's new autoimmunity, and not the entire society being disrupted. I mean, small businesses closed. People's livelihood was threatened. I would love to hear your thoughts about it in terms of your feeling on if this was contributing to the rise in autoimmunity.
It definitely was. I mean, the problem is, as a researcher, it's difficult to measure. How do you measure that? One of the ways that we track trauma is looking at adverse childhood experiences. And that kind of questionnaire, which is well validated, doesn't apply to the trauma of the pandemic. So I would say this experience of the pandemic and sheltering in place and the isolation, we definitely know that isolation and loneliness is a trigger for autoimmune disease. So that is well established. We've got so many concordant studies showing that association. So I definitely believe that that's a factor. It's just something that's relatively difficult to measure. And it's a good point because, yes, sometimes a trigger for autoimmune disease is a virus. Sometimes it's the post-viral situation in your immune system, in your pine network, your psychology, your immune system, your nervous system, and your endocrine system. So I would say the best data that we have is just knowing that loneliness and isolation increase the risk of autoimmune disease. So that's the closest that we can get. And I would say the more research that we have, questionnaires about how people are doing post-pandemic, how are they were doing during the pandemic, how that then correlates with autoimmune disease. We don't have those data yet. It's forthcoming, I hope.
Hopefully. I'm not sure that we'll ever be able to get really clean data to isolate and say these things in particular. So I just want anyone who's listening to know that if you feel like that's true for you, odds are it's true for you and you don't have to wait for a study to validate your experience. And as we were talking about, it can take a long time for us to get research altogether on autoimmunity, but research on women. And not all of us have the next 40 years to wait around and be like, I need to be validated about this study before I actually take action. I move forward with things. You brought up ANA, the anti-nuclear antibody. That's one test. Let's talk about what that is. And let's also talk about symptoms, the top signs of autoimmune disease people should be aware of.
Sure, and maybe we could riff on this because I know you know a lot about this too.
Well, I have multiple autoimmune diseases, so there's that.
Right. Well, anti-nuclear antibody is one of these measures in the blood that is where your immune system is attacking the nucleus of your cells. And pretty much all of your cells have a nucleus with the exception of red blood cells. So it's a very general test. It doesn't point toward a particular autoimmune disease. There are now more than 100 autoimmune diseases. There were just a few when I went through my medical training 30 years ago. But now there's more than 100 of the classic autoimmune diseases, which are a constellation of symptoms that fit together with attack of a particular, usually organ system, and then positive antibodies. So the most common ones are Hashimoto's thyroiditis, Graves' disease, type 1 diabetes, multiple sclerosis, psoriasis. Those are some of the common classic autoimmune diseases. And then there's also what I call non-classic autoimmune diseases, where your immune system is attacking your own healthy tissue, things like endometriosis, adenomyosis, where you are attacking the muscle wall of the uterus, which is something that I've had. And also even irritable bowel syndrome. Mark Pimentel at Cedars has shown that there are some people with irritable bowel syndrome who are making antibodies against their own normal tissue. So with anti-nuclear antibodies, are you willing to say whether you have positive ANA?
I don't have positive ANA, and because I've been on a fertility journey, I get it measured every 6 months. So that's one that hasn't come up. I have Hashimoto's hypothyroidism. So my immune system decided to attack my thyroid. I also have psoriasis, and so which is worse following birth for me, which is common for a lot of women, where I will get some plaques on my scalp, but mine is really psoriatic. So whenever people are like, gluten-free is just a trend, I'm like, I wish. Because if I get glutened in the United States, I can't type. I can't move my joints. They are so inflamed for weeks that I'm like, yeah, I wish it was as simple as that. And then I have had antibodies, 21 hydroxylase antibodies, so Addison's, super bad. No, but I'm like, all autoimmune disease is bad, but that's one that I really harness, I really like check my stress on, because that's one I've never shown any adrenal issues in terms of frank adrenal dysfunction. And I have put those antibodies, I've put all my antibodies into remission, but they will pop up from time to time. And then I also just got diagnosed very recently, 29 years of periods, and finally diagnosed with endometriosis and adenomyosis. So, and as you brought up, that I'm with you. If it's not autoimmune, if they show that there is another cause, I will be shocked, because I feel like at this point we have so much evidence that's pointing to it. It's one of those things that they teach you in medical school. And I find myself saying to my child all the time, like, stop looking for zebras in a herd of horses. If you've got a herd of horses, odds are it's a horse. It's not a zebra.
Right. Yeah. There are studies showing antibodies with endometriosis. Adenomyosis, there's less data. Again, this is something that doesn't get sufficient research funding, but I'm with you. I feel like your body is attacking itself. The immune system is overactivated. There's a difference in the way T cells respond. One of the key warriors of the immune system. So I'm so sorry that you have had these multiple autoimmune conditions. And as you are describing and suggesting, women are also more commonly affected by multiple autoimmune diseases. So most of these conditions that we're talking about affect women way more than men. And it's, the gender gap continues.
Yeah. Well, and it's interesting because when you look at some of the studies, they say by the time somebody gets a doctor to recognize one autoimmune disease, so one diagnosis, they actually have three. Because once you lose tolerance to yourself, once your immune system is confused, it doesn't get smarter a lot of the time. It stays confused. But, as the issue you raised before, and I'll let everybody know, I'll put a link to taking the ACE score, the adverse childhood events. I'll put that in the show notes. That's something that you and I have talked about before. I check every box except for one. I could do nothing about that. I can't go back and change my childhood. I wish it was different, but that really, I had the genes and that set the course. And it's really been a lot of work of going back and healing and working on that aspect of things. So I want everyone to know, like, yes, you can cut out the foods. Yes, you can, you can take all the supplements, you can do all the therapies, but if you don't look at that trauma and heal your childhood, it is very hard to keep those antibodies in remission and to keep that autoimmune disease from progressing.
Well, you and I are similar in that way. I don't have an autoimmune disease that I know of yet, but my anti-nuclear antibodies, right? My anti-nuclear antibodies went down to negative, the normal level. And it was mostly, I believe, through working with trauma. And as you said, you can't do anything about a high ACE score. My ACE score is 6 or 7, depending on who is counseling me about it. But the way that it lives on in your body is something that you can work with. And that is super empowering. The idea that you could choose post-traumatic growth. And I'm someone who ran around with partial post-traumatic stress disorder, kind of hypervigilance, and a lot of the other aspects of PTSD after childhood. And there's a lot that you can do to manage it. It sounds like you've been on that journey along with me, Jolene.
Yeah. I would love to hear some of the things that you have done to management. I actually, and I'm going to share this with you, I'll put this in the show notes as well. I actually just had somebody recommend this Mayan therapy of like working through your trauma that I'm actually going to start. And it was a therapist I was working with, and she's like, "You're Mexican, you should be working with this Mayan energy." And I was like, and I've looked into it. There's YouTube videos about it. And you basically are going back and you're basically trying to bridge the past and now, and basically healing that on the energetic lineage. Because as we know, people will be quick to be like, "Oh, that's so woo-woo." And yet we know that the trauma can energetically imprint in our cells. And we've seen that, I think some of the best data has come out of Holocaust survivors and how that trauma has been passed down, which as I say all of this, people might be like, oh, great. Like there's so much work to do. But let's talk about, when we say trauma, what does that actually mean? Because I think so often people think like the extremes of trauma.
They do think of the extremes. And a lot of folks don't realize that some of the maybe small t traumas that they've experienced also count. They have this signature that can live on in the body. And so you're right. Rachel Yehuda has done such interesting work looking at a few groups of people. She started with Vietnam veterans, and then she looked at Holocaust survivors and their offspring. And then she also looked at survivors of 9/11, and especially the women who were pregnant during 9/11, during the terrorist bombings. And she's found a number of different things. So yeah, it may not just be your own experience of an overwhelming experience, overwhelming traumatic event. It could also be that it's in your lineage and it's passed down epigenetically. And that can be passed down, for instance, with the way that your body signals cortisol. So some of the enzymes that manage the conversion of cortisol to cortisone, which helps to inactivate cortisol, the main stress hormone, you might have inherited a parent or grandparent's tendency to not do a good job in activating cortisol. So that's an example of an epigenetic change that can occur. And I love hearing about, for instance, the Mayan healing that you're describing. I feel like when I started looking at what is the standard of care for someone who's got trauma, whether that's big T trauma, like someone who survived a car crash or 9/11 or the Holocaust, or the small T trauma, maybe a romantic partner who has narcissistic traits, or, there's a way that you are sacrificing authenticity to remain attached in a relationship, or difficulties at work, having a boss who's misattuned and assumes the wrong thing about you. Either one of those and kind of anything along the spectrum can affect these parts of the body that are vulnerable to it. And I like to frame that as the Pine Network that we talked about: your psychology, your immune system, your nervous system, and your endocrine system. So when it comes to the kind of things that have been helpful, when I first started to look at this and I did my first ACE score, which is right around the time that my anti-nuclear antibody was positive, I was really interested in MDMA-assisted therapy because I could see that if the gold standard for people with post-traumatic stress disorder was to go to talk therapy, sometimes trauma-informed, but often not, and to be prescribed a selective serotonin reuptake inhibitor, what I saw, Jolene, was that the efficacy of those things, the gold standard, was about 30% in terms of the resolution of PTSD. 30%. Whereas MDMA-assisted therapy has an efficacy that's more than double that.
And what is MDMA? What is that therapy for people who may not be familiar with it?
MDMA is known by its street name, which is X or ecstasy or Molly. It's I think of it as a sacred medication that's been studied in multiple randomized trials, and it's been shown with 2 to 3 treatments together with integration and preparation to help people resolve post-traumatic stress disorder. It has a way of working with the signature of trauma, especially in the brain, to help resolve some of the stuck pathways that can occur. And importantly, what we've learned is that the part of the brain where trauma has its signature is different than the part of the brain that you might access with talk therapy, kind of the understanding part of the brain. So there's these 2 different parts of the brain. We think that MDMA, when it's given together with therapy, MDMA-assisted therapy with a licensed therapist, that it can help to resolve that trauma signature in the brain. So understanding and talk therapy doesn't seem to do it, but this seems to be a lot more efficacious.
Yeah. It's been interesting now that there's been a little bit of a less barrier. I feel like there's still stigma. So everybody who's listening, be clear. We're not talking about just go do ecstasy on the weekend and you can heal your trauma. This is done with a practitioner. But, we've seen things like psilocybin. So shrooms is what people would call that. And even seeing ketamine therapy, seeing these different therapies now being explored and understanding that by accessing this different part of the brain, as you're saying, people can actually really, it's like, it's almost like turning on the light. And so the shadow is no longer there. They can see it for what it is. They can work with it. And, it's so often, we see like cognitive behavioral therapy. And so often we talk about like referring people to therapy, which is important. But as you were saying, if somebody's not trauma informed, sometimes therapy dredges up things that you then are not given the tools to handle, which is what is very different about what you're describing with MDMA.
Exactly right. So MDMA allows you to look at what happened to you without the story or the narrative that you maybe have always attached to it. So it allows you to look at it with fresh eyes and often with less fear. And when you look at it with less fear, it often allows you to bring in more of a healing approach to it. So I think it's really important. Right now we're in the United States kind of reassessing whether the FDA will approve MDMA assisted therapy. They want more data in more populations, and they want to look at safety and efficacy. Although I would also add that the safety of some of these medications, such as MDMA, ketamine, psilocybin, it's so much safer than alcohol. And yet they're safer than riding a horse. And yet, it's a big threat to big pharma here in the United States. So yes, we're not talking about just a weekend going to a rave and taking Molly. We're talking about a very structured way of taking it. And I also feel like I should add that I've been a total square all of my life, and I never even smoked weed when I was younger. And it wasn't until I was in my 50s and I had this positive anti-nuclear antibody, and I also had conflict with my family member that it got me to consider taking it myself.
And did you find that it was helpful?
Well, my anti-nuclear antibodies went into remission. I did it together with some other things, including an elimination diet. I'm someone, and I'm curious if you had this at all, especially with what you're describing with your ACE score. I feel like in medicine, we're selected for people who can cognitively dissociate, who can, kind of forget about whether they have to go to the bathroom or sleep.
Totally.
Right? Like, you get lauded for working around the clock, 36-hour shifts. And there's a degree of dissociation that has to happen to be successful in that system. So a big part of this work for me was learning how to not dissociate, how to really be fully embodied. And I would say psychedelic assisted medicine has helped me more than anything else with that quality.
Yeah. No, what you're saying is so true. And I think that's where sometimes patients have such a hard time with their practitioner's bedside manner, is that you sometimes, depending on the situation, to be fully present with someone's pain and then to do it again and again it can be a trauma in itself, but it is, if you don't have the tools for it, but we're never given the tools, and we're told exactly that, like, forget about who you are, forget about what your needs are, be solely present for this individual. And so there is a reinforcement there. And I also think that being present in your body is incredibly uncomfortable because of a myriad of reasons, but certainly more so if you've been impacted by trauma.
Great point. And it's, I wish we learned more about this particular aspect, because, You've got your finger on something really important, which is the vicarious trauma of taking care of patients, especially when you're someone who is empathic and sensitive. I'm one of those highly sensitive people, and it's I remember working with a energetic healer in my 30s when I was feeling burned out, and I was seeing 40 patients a day, and a lot of them had, crises that I was dealing with, and I was still taking a woman with a ruptured ectopic pregnancy to the operating room to try to save her life or doing emergency cesarean sections. And there was a way that I was so wide open to these experiences of my patients and had difficulty kind of managing how much I would let in while still being empathic. And it would lead to burnout. It would lead to, sort of one experience burnout after another. And then I would, reduce how much I was working and go on vacation, and it would get a little bit better. And then I'd be back at the burnout situation another 6 or 12 months later. So that's another sign, I think, of the way that you work with trauma. Is burnout part of your experience? Are you someone who's got, this sort of wide open energetic system that can be easily affected by others? And I'm not saying you don't want to do that. It's more that you want to be more skillful about the way that you manage the energy flow.
How would you advise somebody to avoid that burnout?
Oh, such a good question. Well, maybe we could riff here, Jolene, because I know that you've also worked with these things, especially as a woman with multiple autoimmune diseases. I would say first that one's home, whether you're in a committed partnership or not, must be a sanctuary. Must be a sanctuary. And I didn't have that. So I grew up with parents that were divorced. I made some choices in terms of my marriage that did not provide that ability to completely rest and restore and rejuvenate at home. I think that's really essential, especially for women who've got big lives and they're on a mission to help others in a big way. So I think that's one piece. I would say psychedelic assisted medicine helped me clarify authenticity in a way that I was less clear about. And that's part of, this is a whole other conversation, but I would say plant spirits and the way that they can initiate us are very powerful. And then, more on the medical side, I would say tracking my health, tracking on my dashboard some of the levers that I think are so critical. So for me, for instance, anti-nuclear antibodies, measuring the amount of inflammation in my body, being able to track how to navigate that and do N of 1 experiments to see what improves them, such as MDMA assisted therapy. That's been very helpful. And then I think this is related to relationship. There's a level of sovereignty that I think is critical, where you're not looking to others to be validated, but you've got this internal sense of sovereignty and boundaries. And then last, I would say, is regulation. The list goes on, but I would say really understanding what it looks like to feel regulated, to have your hormones kind of at your back and supporting you and not working against you. So what did I miss, Jolene?
I love that last piece of being regulated, but also recognizing dysregulation as it's mounting and it's building. So, and this leads into certainly identifying if you are neurodivergent, you're going to be more apt towards burnout just because of the sheer volume of information that you process at a much higher rate than the neurotypical individual. So I'm speaking to autism and ADHD as well. We know a lot of women have fallen through the cracks. But when we hear dysregulation, that's usually the population we think about. And yet dysregulation can happen to any of us. So that's the the being in your body and going back to that, noticing your breath, noticing the tension that you hold, noticing, and giving yourself permission. The sovereignty you talked about, I think is so key as well. Like if you're in a situation, so for example, A4M, this is a medical conference that happens every year. It's a great conference, but I will only speak there about, I'm like, maybe every 4 years, guys, because the sound of Vegas, the smell of Vegas, the lights of Vegas, everything about Las Vegas leaves me dysregulated in my body. And then there's the performance, as you know. I think sometimes when you are a speaker and you do it well, people are just like, it's so natural. It's such a gift to you. And you're like, I am like noting what your face is doing in the audience and do my jokes land and are people and there's just so much going on. And so all of that is to say from my personal experience is like, I go in, if I'm walking through the casino, blue light blocking glasses are on. I also do that if I go to Costco. I wear noise canceling headphones a lot of places or earplugs in my life. If I want to be like covert, I have loop earplugs. But even going into restaurants or stores where they think blasting music makes for an ideal experience. All of these little inputs I know add up over the day. And I will say that I have to, if people are like, this is so much work, I have a toddler at home. So getting that space at home can sometimes be more difficult. So it's a season of things. So I think there's what you can do preventatively, but there's also noticing how your body's feeling. And if you can remove yourself from situations, if you can have a practice. I know you talk about deep breathing practices. I mean, the research definitely supports that. Why don't I let you explain to people, you have your own practices around deep breathing and using breath to regulate your nervous system.
I really feel like those of us who have had adverse childhood experiences, especially before age 3, we benefit so hugely from daily practices that help us regulate and reset the nervous system. So I do it every morning. I was outside by the beach this morning doing deep abdominal breathing for about 30 minutes. So I find that is really helpful. I became a certified yoga teacher in my 30s, mostly because I needed it to function. And I needed it as, more than a balm, like a bellwether, a way to assess my own regulation, although we didn't really call it regulation back then.
Mm-hmm.
So I practice yoga. I can't always sit. I'm sort of a fidgeter, and I've got ADD, which was diagnosed in perimenopause, very common.
Yep.
So yoga is something that still really helps me. But I would also say, I've been practicing yoga for 50 years. I learned it from my great-grandmother, and yet it wasn't enough for me to resolve the trauma in my system. So it helps me, and it's part of a daily practice. And I'm also a fan of some of the other breathing techniques that I talk about in the book, like holotropic breathwork, which is a good alternative for people who don't want to try psychedelic medicine.
Wait, explain what that is. The first time I did it, I was like, this is the most magnificent thing I have ever done with my breath. But for people who don't know.
So holotropic breathwork was developed by Stan Groff, who was a psychiatrist and still lives in Mill Valley, not far from me. It's a way of breathing where you are hyperventilating, and it just allows for this physiological change in your body. The way I think of it when I practice it is that I'm making my own medicine. And it can be psychedelic. It can take you on journeys. It's funny, the first time that I did it was actually at an A4M conference. And I'm with you. I'm with you. I go to A4M, and it takes me like a week to recover. Just the casinos, the noise, and having sensitivity, it's just really tricky. And there was a dome at the expo maybe 5 years ago at A4M where they were teaching people how to do holotropic breath work. And I went in, it was like day 3 of being at A4M. I had a mild headache. I was dehydrated. I wasn't sleeping well. And inside of 20 minutes with holotropic breath work, I felt this complete reset. So I'm curious about your experience. What did you find, Jolene?
So it definitely felt like, as somebody who hasn't experimented enough with drugs to say for certain, it is something that it did feel like that everything that you see like in the media about what a trip would be like, it felt like that, like this out of body experience. But I just remember feeling like when I came to the end of it and really reset and grounded, it was like my soul dropped into my body and I felt so clear and so present and unbothered by so much stuff. As I say, unbothered, I'm like, that's really been like the energy I've been channeling. As you know, being on social media, it can sometimes be a very interesting space of a lot of people projecting trauma that you're not here to heal them. And I've been channeling unbothered. So as that comes up, I'm like, oh, I think it's time to go back and do some of that breathing. It's time to practice that. And I think that, for people who are like, I don't know about giving up control, because these psychedelic therapies you can feel that loss of control and there can be that fear. This can be a good step towards that. And maybe it's enough for you. And that's a beautiful thing, that if we can find interventions that, have the least amount of side effects, but you can also do on your own and be practicing in a way, and that creates change for you. I think that's beautiful.
It's a great portal. It's a great way to get started with some of these healing modalities. And even Michael Pollan, with his work with psychedelic assisted therapy, he couldn't take MDMA because he's got a heart condition. So he used holotropic breathwork as a way of accessing these healing states of consciousness. And that's what we're talking about. We're talking about, what's the best way for you to access a healing state of consciousness? It doesn't have to involve taking a medication.
Mm-hmm. And so people are clear. You've talked a bit about cortisol. What happens to the body? What happens to our hormones when we're in that trauma, that space of trauma?
I've been studying this, feels like, for decades, because apparently I still need to learn like the details of this. So what we know is that when you experience a threat, and that threat could be a physical threat, it could be an emotional threat, it could be the tone of your partner. When you experience a threat, usually adrenaline, epinephrine rise in the bloodstream. So they get released from the adrenal glands. And then cortisol is close on its heels. But really what we're designed to do is to have a stress response like this rise in cortisol and to resolve it within 90 seconds, at the most 90 minutes. We're not designed to have these stressors that come up multiple times in a day and to have these elevated cortisol levels. So I'm someone, when I first started testing my cortisol levels in my 30s, I'm someone who had really high cortisol levels until I started to manage it and navigate it and find through N of 1 experiments what worked best for me. But the issue with cortisol, and I want to hear a little bit about your own story with cortisol. The issue with cortisol is you want it to be in that Goldilocks position where it's not too high and it's not too low. And my issue was high cortisol, someone who's just got a kind of high level of perceived threat most of the time. I've been able to bring it back to this Goldilocks position, but you can also burn out over time. And it can lead to high cortisol for a period of time, like with 21 hydroxylase antibodies. And then you develop low cortisol, or even a combination of low and high within the same day. So that's part of the story with cortisol. And it's not one of those hormones that's in isolation. It affects so many other hormones. It affects your estrogen progesterone balance and your testosterone. And it can be associated with depression. It can even be a suicide marker. So what about you, Jolene? What's your experience with cortisol?
It really took my son developing pandas for me to get the reset that I needed. So people, if you are not aware with that, what that is. PANDAS is pediatric autoimmune neuropsychiatric disorder associated with strep. He got a strep infection. It triggered an autoimmune attack on his brain. He had lots of inflammation. And overnight he went from, so my husband and I were talking about how at 6 months, he said his first word, and how by the time he was 18 months, he could speak in sentences. And that's not normal for a child. So you guys know that's very, very early. That's how verbal he was. But when he got PANDAS, he no longer could speak. He would just cackle and make the most out of this world noises. Anyhow, and I could talk forever about that. I had been testing over and over via saliva, be it Dutch tests, like every 6 months, checking my cortisol levels. And sometimes I would bring them back into normal, but more often than not, they were the high normal in the morning. Like I was waking up in a panic. Like that's what it looked like. Like I was in full fight or flight. I also have the genes, so I don't clear it as well. The warrior genes. Once upon a time, in a different time, I would be a warrior, and that would be fantastic. I would be able to go to the battle, and I'd be the person like 3 days fighting nonstop. But I'm a modern human now, so that doesn't serve me as much. I want people to understand that these once upon a time served us. Now we have this bit of a mismatch. But it was once my son got sick, and I realized how much it was breaking me down and how rapidly, as I continued to try to run 3 clinics. And this happened right before my book Beyond the Pill came out, and just everything that was going on. And I realized that really I was given an opportunity here to change my life altogether. And I could choose life, or I could choose the burnout, the breakdown, what was inevitably coming. And I shifted everything. And I decided that I was like, the pinnacle of success in terms of what we're told as, doctors, like you're running 3 successful clinics. You have this full patient load. Like you are so successful. And yet I was like, I am not showing up for myself anymore. And I'm not entirely happy operating in this way. And so it presented an opportunity, and I had to shift because, number one priority is my child. I brought him into this world and I needed to help him heal. But it was through all of that, I really rearranged my life, my perspective. I got serious about rituals and practice. And in all of that, I finally, what has it been now? Almost 6 years. And I've had a normal cortisol. I could almost cry, because if you're somebody who's ever operated under high cortisol, and especially as a doctor, of like, here I was helping everybody get their cortisol in check, but like I felt like internally this shame of like, why can't it work for me? Why nothing is working for me? And it was because I was in such misalignment with who I was supposed to be in this world and how I was supposed to operate in my entire life. So I will say that for the last 6 years, I'd say more like 5, like when we got out of that acute response with PANDAS, that things have shifted. And that makes a tremendous impact, as you were saying, having easier periods, less PMS. I think I was blessed this to happen in my 30s, because if it happened in the perimenopause, like peak of perimenopause, I would have probably lost my mind. Like I would have, it would be so much harder, because already progesterone is no longer your bestie. She's just leaving you. But, something else that you brought up was the mood aspect of things and how it impacts depression. And you brought up SSRIs earlier. So I'm sure people are curious about the impact of the hormones, the trauma on their mood when they're being faced with like, all you can do is an SSRI.
That's right. I mean, you and I have a mission about supporting others and helping them through the dark times of things like depression, PMS, and the difficulty gaslighting, dismissal that they might experience with conventional medicine. And so when I went to my doctor in my 30s and I had PMS and I had one baby and I couldn't lose the baby weight and I had a lot of belly fat and I just felt stressed all the time, he offered, which you might imagine, he suggested I take a selective serotonin reuptake inhibitor. He suggested a birth control pill because it sounded like I was hormonal.
Mm-hmm.
And he told me to exercise more and eat less. And so it was at that point that I left his office and I marched over to the lab and I scienced myself and found that my cortisol was 3 times what it should be. So I feel like what's important to know about cortisol is that it's really a dictator in the body. There's not a democracy with these hormones. There are certain hormones that are more important than others. And cortisol, if you don't have cortisol, you can die. So you have to have sufficient cortisol. And that means that it's involved. It's got its tentacles in so many different functions in the body, including your mood, including the way that you signal some of the brain chemicals like serotonin and oxytocin, norepinephrine, pregnenolone. And when people have mood issues, I think a hormone panel is essential. And if you've got a clinician who's not willing to order a hormone panel that includes cortisol and DHEA and estradiol and progesterone, then you might want to find a new clinician who's willing to order them. So I think it's important to realize that hormones are often at the root of mood disturbance. And it's not as simple as let's just throw a pharmaceutical at it. So we want to look at, okay, what are the root causes? And then how do we address those? First with lifestyle redesign, maybe with some supplements. And only if life-saving or, really essential, use a pharmaceutical. And I'm not anti-pharmaceutical. There's time and a place for them. It's just that I think we hand them out way too readily.
Mm-hmm. Why is it so controversial for doctors to test women's hormones?
It's such a good question. So here's what I was taught. So I went through an obstetrics and gynecology residency, and I remember there were sort of two different camps. There was the camp of, here's basic gynecology. We're going to teach you women's health. And if a woman asks you to check their hormones, then you don't do it. You tell them it's a waste of time, that hormones fluctuate too much. And then we would go work in the infertility clinic and women, with women with polycystic ovary syndrome, women with unexplained infertility. And we would check every hormone. We would check day 3, estradiol and FSH. We would look at progesterone. Did you ovulate? We would look at cortisol and thyroid. And so there was a double standard. And I think some of that is set up because we put a lot of value on women's reproductive health.
Mm-hmm.
We put more value on reproductive health than we do a woman's well-being.
Mm-hmm.
And then it gets promulgated in the training that we go through. So I would say patriarchy is the cause, and also just the way that we're so biased toward fertility. But I imagine you've thought about this a lot too, Jolene. So what do you think is at the root?
I absolutely agree. And sometimes it feels like all we are reduced to is our baby making capacity. And once you are no longer in that window of being reproductively viable, of somebody who could produce offspring, medicine is perhaps even faster than society to discard your value and to discard your, and what I mean by value is your well-being. When you look at, I was shocked. There's a new documentary coming out, and to see all of these medical doctors saying, oh, I got no training in perimenopause or menopause. And my jaw just dropped because I was taught about these things. I was taught how to prescribe hormones. I'm like, shout out to Dr. Winstar, I think in part because she was in perimenopause teaching our gynecology. And I was taught about all of this. And so for me, hearing that, it was such an aha moment of, we've been, I think so often very vocal about how doctors don't get enough nutrition education. But I think what we have to pipe up more about is that they don't get enough education on women's health outside of, is it disease or can it make a baby? And it is so sad to me how, because we, Dr. Mosconi, who'd said, like, we should have never named them sex hormones. It was like the biggest disservice, because it was with naming them that made them all about reproduction and nothing to do with heart health, brain health, every other way that it impacts us. So I think it's absolutely true. There's the lack of education. There is the, dismissal that if it won't impede your ability to make a baby, then it really doesn't matter. And I think that's why we see, looking at the research, that women are spending the last, 20% of their life in the worst health of their entire life. And so that is part of why we do what we do, because that narrative really needs to change. And we spend so little time on this planet that it is, for me, there's no time to waste. We cannot spend it feeling unwell.
That's right. And, this is where we want to galvanize women to not put up with this anymore. So those days are over. The days that, when I was taught that menopause was ovarian failure. Mm-hmm. It was where your ovaries stopped working, and really there was less attention paid to women. There was a way that women disappeared after their ovaries started to sputter and then fail. And I don't like that language. We don't have to put up with it anymore. So we can demand that there's more education for clinicians. We can demand that the clinicians that we see are willing to have conversations about this and have a growth mindset and are willing to learn. Or you move on to another clinician. Like, find someone who values the experiences that you're having, who is willing to test your hormones and is willing to collaborate with you to help you feel your best and function at your best.
Absolutely. And on that note, I think that's a beautiful place for us to end our conversation. Although I could talk to you, as you know, and anybody who's listening probably has caught on, we could talk forever. But I really do appreciate you taking the time to speak with me today, to share your insights with everybody listening. We will link to your book, your social media, all the things in the show notes. But I just want to truly thank you for all that you have done, not just here, but just in all of your work, the lifetime of you.
Thank you, Jolene. It's such a pleasure to be with you and to collaborate with you. I just love hanging with you.
I hope you enjoyed this episode. If this is the kind of content you're into, then I highly recommend checking out this.